buttons. I feel good about it. Okay.
Yeah, that's fine.
It says we're live. It says everyone can hear us. Oh, it's got a new button. Okay. Anyway. All right. Welcome to the Health Tech Talk
Ooh.
Show. Magic edition, maybe, except for not. Just so everybody knows, we never know what the graphics for our weekly show are going to be until right before I post them.
Mm.
Max Kowalczyk does these and we just like never know. So this is this week's. Who knows what's going to be next
No,
week? We don't
everyone
know.
is always like, Kat's graphic design skills are amazing. I'm like, that is Kat's
I
sibling,
don't do
y'all.
them.
How many times have
I
you said
have
this? You're like,
Like that's the thing. I feel like I give Max like all the credit. Yeah. Also, Max is my youngest sibling. I'm one of five children. She's my youngest, and she is in Senna's production artist. So I do not do the graphics here. Just in case, I usually say I need eagles and fire, but I do
put
not
some
in
more
fact do them.
eagles
But
on it.
yeah,
And they're
yeah.
like,
That
okay,
usually is the
sure. Yeah.
feedback. Make the eagle bigger. Yeah. So that's usually what happens. But
Amazing.
anyway, Lisa, what happened this week? I don't know. I was like not totally paying attention. I had
Holy
to bill hours this
smokes.
week. That's the
Oh,
problem. I had to actually bill hours. So, I didn't get as much bullshitting time as I usually do. It was a real bummer.
I did not. I've been on kind of half-assing taking a vacation, which is very difficult. My dad and my I guess his wife, technically my stepmom, but we're all adults here, are in town from New Zealand. So I've been in and out doing random various things. I bought an e-bike today. I'm just moving right into older adulthood, just moving right in along with
Oh my
hopefully
God.
the e-bike will speed the path towards menopause. That's the goal.
That's
We're
what I was
trying
just
to
gonna
just
say. This is
that's
like
the goal.
I cannot I cannot wait to take this journey with you. I hear
Oh my
as we
god.
know, we do hear that both perimenopause and menopause actually sucks. But like Lisa, like I'm looking forward to like virtually holding your hand through the whole thing. It's gonna be amazing. Who knows what's
We're
even
ready.
gonna
We're
happen?
ready. We're
But I'm
ready.
excited about the e-bike. That does fit. Yeah. Well, lots of news to come on that. That's great.
Yeah.
Okay. All right. So here's our new show. So as usual, we see what the algorithm on LinkedIn sends us, and then we say the things that we're going to post on here. Also, we mine Health Tech Nerds news channel for stuff. So first off, I think everybody knows the Change Health cyber attack was like Change Healthcare cyber attack was like pretty bad, and I think providers are still like not totally getting paid, from what I understand. Is that correct, Lisa?
What I've heard is that it's very very slow going slash not resolved. United Healthcare has been like giving out more loans, but that's not really the same as like paying providers for like the
Yeah.
services that they provided and like processing those medical claims. So I think it's still pretty tenuous for a lot of folks. And you can be like, oh, they're going to be fine, but they're like, well, my bank account is empty, and if it's empty, I can't actually pay anyone who works for me to actually operate this clinic. So what should I do? Like, it's just kind of a no-win situation, and United offering more loans is like not the solution, in my opinion.
Yeah. So this is our BFF Preston Alexander. Everybody should follow this guy. He has a great newsletter. I think it's a Substack called the Healthcare Breakdown. He does a lot of math. So if you read this, it says yes, United Health Group lost $1 bajillion, but they made $100 bajillion, and through finance math, somehow they still took a loss, but they also made money. So like I don't know. So overall, it sounds like United Health Group is fine.
Well, this is
They're
related to
doing
my
okay.
taxes, which are a big question mark, but like I made some losses, but I also made some gains. It's pretty confusing. I mean, the whole goal is to confuse the IRS
Oh
enough
my
to like
god.
be like, yeah, yeah, looks good. You totally paid us enough taxes.
Yeah.
Bye. Like,
You
finance math is
know,
really. I appreciate that about Preston. Like, there is a lot of, especially look at the balance sheet of any nonprofit hospital, and there's some finance math happening there.
oh,
So
it's
good stuff.
incredible. Yeah.
Yeah.
I mean, for people like me who don't know how to do math, like, and don't believe in
Mm,
math, as you know, this is why I have an
mm,
accountant who does my
yeah.
taxes
Yeah.
because
Yeah.
I'm like, that's
Same.
not real. But anyway,
Right.
yeah, like, his stuff is really good. And I actually like learn a ton from it. And
Yeah.
he writes it on like, sixth grade level. So people like me can understand how to do math. So that's great. Follow
You know.
Preston. He's great. He's great. Okay, so this I stole off the Health Tech Nerds news, and I should give credit to the poster, but I cannot remember who it was. But it might have
Sorry.
been Jim St. Clair. I feel like that guy's always on there. But anyway, so I wanted to post this on here because this is like, if you read this article from NPR, it's about, I think it's the billing code that came up in like 2015, 99490. And it was so that practices could bill for chronic care management, like basically like giving someone a call to see how they're doing at home and like taking better care of them. I think it's
How's your
with
blood
Medicare and Medicare
sugar?
Advantage.
Do you need
Yeah, like,
anything?
oh,
Whatever.
we told you
Yeah.
to exercise. How's that walk going? Right. And like and what this article says is like on the surface it was a great program, like totally cool, totally legit, but like it turns out no practices were set up that way and couldn't afford to staff that way. So like in fact, like no one's really using it. Some practices are. I remember there was that whole wave, speaking of the hype cycle in AI, which I know we're getting into, there was that whole wave of companies that popped up to do CCM, chronic care management, and like it like didn't work. It like didn't work, but could have worked, and that would have been great. And one of the things that the providers interviewed for this article cite actually is that they were concerned about giving those vendors patient data, which I thought was interesting. I used to actually work with a couple of companies back in the way back about on this, and that never came
Yeah,
up. But
same.
that might have
Ab-
just,
ab-
yeah,
Absolutely same. And you know, again, like fee for service is not the solution to chronic care management. You heard it here first or probably last, because honestly, like we've seen this so many times, right? I mean, providers, physicians, primary care, they need population-based payments to do the right thing for the right people. They don't need to bill like something else. Sorry, we all love billing codes. Yay, billing codes. But like
yay.
they need population based payments. They need to be generous. They need to be prospective. That means paid in advance. Like all those things need to happen to be able to provide this kind of solution. But sure thing, if you want to like provide some billing code opportunity so that someone else can start another tech company to do this, I'm sure there are plenty of people waiting outside the doors of Y Combinator, banging on the door, saying, "Let me in. I have a plan. I'm new to healthcare. I'm new to healthcare,
Oh
I'm new to healthcare. I came from Uber, but I'm ready. Sorry, Lyft,
my god. Yeah.
from anyone else, whatever.
Oh
Look
my
at me,
god. Oh my god. Yeah.
God.
Yeah. Or like,
I'm a
yeah. Or like, hey,
little grumbly today about this, so here we go.
no, I'm here for it. I do feel like there's a lot of that. I feel like there's more and more, more like early folks that I talk to too. Have you noticed this where they're like, hey, I just went to Mexico and did a bunch of mushrooms with like my tech
Yeah,
friends, and now we're starting a healthcare startup. So maybe
perfect.
we'll see something soon. I don't know, but anyway, this is I think an example of like really good thought. Like this was a good idea. It's just like wasn't implemented correctly, which I know is a theme for you, Lisa. It's like one of your favorite things to discuss. So yeah.
My
Ah,
startup that I started when I went on an ayahuasca trip in Mexico is totally food as medicine. I'm sure. I'm just guessing. They're like, you know what
Lisa,
would be
oh my God.
amazing if people would just eat right and we could help them. We could tell them what to eat. Yeah, man. Awesome. Let's go to Y Combinator. The end.
Oh my God.
That's the
Where's Mitty? We
story.
should call Mitty. We should call Mitty.
Story in one part.
Oh my God. Jesus Christ. Oh my God. Well, I'm
God.
glad that you're on fire today because I had to drive through Atlanta traffic and it like took all of
Jesus.
my energy. So like I don't have any
Yeah,
right
yeah,
now.
yeah.
I don't know. I don't know. I
It's
don't
fine.
know. Yeah. Jim St. Clair did confirm. Apparently
He
we have
did.
audience comments in Vimeo. He did post the
Oh
99490
no,
CCM.
Nadine says
Uh,
Tyler did. I don't know, whatever.
oh, well, who the
There's some questions
hell?
here. Some
Well, I don't.
questions.
I did MA. I don't know. Who know? Anyway, the point is, someone posted it, and you should pay health tech nerds or
And they were
whatever hundreds
great.
of dollars.
Yeah.
Yeah, that person was great. God bless you. Okay, Lisa, tech
Yes.
giants, AI. What do you think about this? What do you think about tech
Okay.
giants?
Okay. Okay. So remember when everyone says like alternately either AI is like no big deal, us, or AI is going to like kill the entire universe. We're going to explode into flames. It's all going to be, it's over for us, right? There's two like really prevailing narratives right now, especially in healthcare. Everywhere though, big deal. Okay. Well, turns out in order to train the large language models that exist today, they've actually used up all the language. Like every word,
All the
like
language.
there are no more words to be trained on. Like they're all gone. They read the entire internet and they have no more things to read. So like, crap, what do we do? So OpenAI was like, I know, we're gonna scrape YouTube and literally transcribe every YouTube video totally against copyright. Who cares about copyright? Nobody cares. And
No one cares.
they did it, and Google was like, hey, looks like OpenAI is scraping YouTube. And then they were like, should we stop them? And they were like, no, because we're doing it too. Amazing. So basically, all of these big tech companies have been just completely scraping the entire internet, caring less than 0% about copyright or anything like that, and just doing anything they can. They're running out of. They don't have any more language to train on. They read the entire internet. There's nothing else to do. So what does this mean? It means they're going to use synthetic data to train their next models, and then they're going to collapse in a pile of garbage because models are not successfully trained on fake data. It's going to be amazing. I just really think everyone should take a little breath, me included. Like, this is just not like there is an upper limit and we've almost reached it. And there's not much else.
Oh my God. But you know
So
what's encouraging about this, Lisa, is that because they've run out of words, they've definitely read all of our LinkedIn posts, and we are like a part of this.
Part of it.
Like,
oh my God.
Like the AI is going to be able to write campy LinkedIn posts with like some zingers in there once in a while. The only hope is that I don't know if they'll be able to replace us in the Health Tech Talk Show, but now that we are on YouTube, I bet they're transcribing our shows.
That's
well,
fine.
so.
That's fine. I just really think people should remember that like this is a big scam. This is a scam. Like, it's not like, no, we have not reached AGI. Like, no, these things can't go beyond what they've already been given. Yes, they're incredibly, incredibly biased by like very limited training data. Yes, they're almost out of training data. And no, like, these things should not be unleashed fully on the healthcare system without massive controls, which, leads us to maybe at some point there'll be a comprehensive data privacy and protection law and more and better laws against sort of how we think about using AI in healthcare. It's pretty dangerous to do this weird stuff without any validation. So,
Lisa, why do you think we do not have a comprehensive law protecting data?
Lobby? I think so.
What?
I know.
What?
Crazy, right? It's crazy.
Oh my God. I can't even take it. Oh my God. Anyway, so Lisa, are you also saying that AI is dumb? Or is it still dumb adjacent?
It's dumb and it's dumb adjacent, right? There's like some kind of uses that are like dumb adjacent and some that are just dumb. Like, come on now. And there's lawsuits too, right? Like, what are like the cornerstones of like American democracy? Like lawsuits, lobbying, what else? Lawsuits, lobbying, no zoning laws. I don't know, whatever it is.
Zoning laws.
And there's so many lawsuits. Oh, that's just Texas and Georgia, I think. But there's also lawsuits about this right now. Like New York. Yeah, the New York Times is like suing OpenAI or whatever. So there's this we'll see how this all plays out, but it won't happen very quickly.
Yeah. Interesting stuff. So I think this is George Gooch who's commenting. We only have George, Jim. I know who Deanne is. Deanne, it's coming. Hey, it's one of the next slides. We're just taking a while to get there.
We're almost here.
I assume this is George Gooch, president of the Great Free South, aka the state of Texas. He says, when do Gen AI companies start locking people into lifetime data subject contracts to supply them for free? I don't know, George, but I do appreciate this is what you're thinking about as the president of Texas in at least health tech. All right, moving on. Cerebral just had to pay $1 bajillion because they were bad guys. What do we think about this? I saw Farzad's tweet. He basically was like, you actually have to try to get fined this big. Like, is that true?
It's a lot of money. I mean, relatively speaking. But I think the funnier part is that they like can't pay it, right? They're like, we don't have enough money. Sorry, we're broke.
Well, that is a problem. That is a problem.
You gotta shut down.
And then so speaking of privacy and data, so the particle epic debate continues, at least a little bit, it seems like. And Brendan Keeler, who is probably going to run for president of our market, he just wrote like a pretty thoughtful article on, which actually goes into secondary use, where there actually is some like, I'm not just saying this because he featured me at the top of his article, and I love attention in all forms, even sometimes a little negative. But it actually is pretty thoughtful. Like, all of his stuff has been pretty thoughtful, I think.
He's been doing shout out to Brendan. I told him this privately as well. But I think he's doing a really good job, like bringing some really complicated concepts together. And so like, if you're new to this, like national networks and like data use stuff, I do recommend reading his 2 posts so far. I'm sure it's a multi-post series. I can only imagine there'll be multiple sort of follow-up episodes here, but he's done a really good job making it pretty accessible for people who are even new to the area. And I think knowledge and
Yeah.
understanding, like some sunlight on the topic is really important. Like these are not straightforward issues for the most part. And really taking some time to get to know what's going on is helpful. If you are in health tech generally, without a doubt, if you're in health tech, you have to use data in some way, shape, or form, and probably trying to figure out how to get it, how to use it, all the rules around it. Again, definitely recommend reading these two posts.
Yeah, no, he's done a great job. So up here, he has a Substack. I think it's like healthapiguy.substack.com. I don't know. Anyway, you should
Mm-hmm.
subscribe to his stuff because it's pretty good. And then, actually talking about secondary use though, I know like there's, we're each on like 72 text threads about data exchange right now,
Minimum.
which is kind of awesome. But the interesting thing is like actually secondary use has come up as something that should be removed from the
Mm.
national exchanges as allowable from TEFCA. And like I know we've talked about that, Lisa. Like my issue with that is that there's no way to make money off of any of this unless there's secondary use or federal funding. And we know the latter is not there. So yeah, you remove secondary use, then the primary pool is just more expensive and may become cost prohibitive. And I don't know.
Well,
I
I
don't
mean,
really know if there's
I
like
like, as you know, I like organizations who don't have to make a profit off of this work because they're nonprofits. But that's where we differ, right? So
what.
I would say don't make money off of health data. That's not realistic. Obviously, there are tons and tons of companies doing this work, but the companies and the organizations that I work with are generally doing it for benefit to their community, nonprofit, not seeking a profit. They have to make
I
money
know you can
to cover
make a
their
lot of
costs.
money as a nonprofit. I know some
They
nonprofit
have to cover
CEOs who
their
are
costs.
raking it in, and the cost of their exorbitant salaries. But
I
that's
mean,
not
I did
always
just
true.
buy
Those
an
are
e-bike, so send me to the guillotine. It's fine.
yeah. But anyway, it's fine. We can everybody knows that we do not agree on this issue. That is fine. But
That's
anyway,
right.
subscribe to Brendan's thing. He's done a really good job. I think. I hope that when he figures out how to monetize this, and maybe he already has, he tells us how to monetize the Health Tech Talk
I
Show.
think it's a paid. I think he made those posts available for free, but he has like a paid subscription. By the way,
Oh,
yeah.
okay. Well,
Subscribe to Brendan,
we'll go support him.
maybe.
Yeah,
If he doesn't,
President
like maybe
Brendan
he'll
for
do it
president.
now.
Maybe he's reached critical mass. I don't know. Okay, then we've
Totally.
got this APRA, as Deanne mentioned in. I don't know. We've got like multiple
APRA.
comments going on. Anyway, Lisa, tell us about APRA, not to be confused with ARPA.
Yeah, not ARPA, APRA. There's nothing government loves more than a great acronym. The American Privacy Rights Act. This was kind of like dropped, sort of like surprise, as a bipartisan, bicameral, successor to last year's privacy bill, which had an even longer, more obnoxious acronym. And this is really an attempt to, as we've been calling for, and by we I mean me, like every week, every single day I talk about this, calling for comprehensive data privacy and protection legislation in the United States, a law, just like other countries have, that says like, hey, you can't just randomly sell all of our data up the river. You have to allow people to delete it, have to know what happens, things like that. In this case, this law would basically exclude or carve out HIPAA. I'm sure we'll get a little more of that from one of our illustrious guests in a moment. But it also offers a right of private action, meaning that basically, if you're a company who is subject to this proposed law, which excludes like small businesses and stuff like that, and you actually do something that's not allowed with someone's data, you can actually be sued. Like they can bring private action against you and get something out of it. And they also are not allowed to require arbitration. If you ever read all of those like long terms and conditions, which nobody ever reads, it's always like, you agree to arbitration. LOL, JK, you'll never get anything from us. Go to hell, is like what it says at the bottom. And so this is no arbitration. Amazing for trial lawyers, like big win for the trial lawyers of the world if this actually
Oh
passes.
man.
But there's some good and some bad in it. It happened really quickly. So they just had a hearing yesterday in House Energy and Commerce, which is where this would live. They have a data subcommittee. And it sounds like it went okay. They did a bunch of privacy stuff all in one big hearing, like children's privacy laws, other privacy laws, this one, APRA. And there were some issues. In fact, hilariously, this might get blocked by Ted Cruz. So funny. I love it. And then, even funnier for me, my personal connection to this is that I, as those who are loyal followers of my idiotic LinkedIn page will know, I sat next to Nancy Pelosi on the flight back from DC last week, and I didn't ask her about APRA. I only checked in, as George is saying here in our comments, that Nancy is the reason why the predecessor bill wasn't brought to the floor for a vote, because she didn't want the California privacy law to be preempted by this proposed federal law. So basically, in this whole time where there's been like no comprehensive law, all these other states have started passing their own laws, and this law, APRA, would preempt those laws, which makes every state government like mad. She's like, hey, this is our thing.
Oh,
That's why Nancy didn't bring it to the floor. Damn it, Nancy. And I didn't
damn
ask
it,
her.
Nancy.
I'm such a doofus. Like I was like, I did show her the particle news. Like I was like, hey, have you heard of that book, Nancy Pelosi?
What do you think
She's
about
like,
health
whatever.
data exchange?
What do you think about health data exchange? She's like, no one cares. No one cares except for me.
Red wine, please.
Yeah, I'm like, red wine. She's like, but I could have asked her about APRA, and I didn't because I'm a goober. Sorry, everyone. And really, this is what happened. This is why it took so long the last couple of years, because she would not bring it to the floor. There you go.
Damn it, Nancy.
There's your
Damn it.
window
Well,
into Washington.
God bless the states. God bless the states. Okay, well, on that note, we are going to switch to I feel like I should do an intro for Lucia, and then you should, Lisa. So like, back when we were both like private sector PR girls, like everybody knew who Lucia Savage was, because like all this stuff was coming out about like laws and shit. And now she's at Omada, I think also as the chief privacy officer. So we asked her to come on our show. Listen, Lucia is our only guest ever who we actually agreed to write questions for so that her PR team would approve her attendance. So we actually did some work
we're not writing questions for you.
We wanted her to come up. Yeah, sorry, y'all. I don't know. Sorry. But anyway, we wanted her on because I don't know if anyone's noticed, like at all the social media, we're learning that like all of our longtime health tech colleagues don't know what HIPAA is, and also are conflating it with 21st century cures. And like there's all kinds of trauma. So we wanted Lucia on to like tell us what HIPAA means. Lisa, what did I miss in that intro?
That feels a little basic. I just think
all of it.
It must be funny, Lucia, to be you and to see all of these discussions that are like probably all wrong in like new and unique and also the same old boring ways. That's my interpretation. You tell me.
I will just say that people have to remember what the acronym stands for, right? The health insurance, so insurance, portability, so that was continuation of coverage, and accountability, which was digital claims to the government so that they could, guess what, do population health and fraud analysis. That was the purpose of the law back in 1996. And privacy was a derivative issue that had to be solved because we were digitizing the way providers and physicians get paid to take care of people in government programs. That was the gist of the accounting, is literally what you're all calling secondary use. Let's use the data for analysis. That was accounting. So I think the whole discussion about secondary use is kind of beside the point.
Nice. Oh, and also reminder for everyone, no privacy in HIPAA in the actual name of the law. This doesn't say privacy. Common misconception.
That's right.
Privacy.
Just to be clear, privacy is a really important part of it. But let me just finish. It's a really important part of it, but it became an important part because Congress wanted to digitize the claims data.
Awesome. Lucia, please introduce yourself for real. Tell us what you actually do. Yeah. And then tell us why secondary use is no-go.
I don't want to talk about that. So I'm Lucia Savage. I'm head of privacy regulatory and public policy at Omada Health. Obviously, Omada is, we're 12, almost 13 years old, I think, this week. Digital health service provider. We provide services in diabetes management, hypertension management, diabetes prevention, and telephysical therapy. We don't sell products. And I would just say if they would actually let me write a blog called Forget the App, I would, but everyone thinks that's slightly antagonistic. But we really have focused on kind of like delivering traditional protocols, but through new modes.
Okay. Right on. That's legit. Okay.
Well, so, and also like in the cinematic universe of the diabetes prevention program, right? Like, like the part of that, just part of that work as some weird nerds from CMMI know, the virtual diabetes prevention program didn't get expanded as such. Took quite a long time. Our friend Darshak Sanghavi was involved in that, but that universe of like, okay, this is a path that eventually, it will be recognized, and there's value here.
That's a whole nother podcast, Lisa. You have to have me back.
Sorry, but that's Omada.
Yeah, and we have to.
We have a plan.
We have to get. We have to get that approved. We have to get that approved. Okay, Lucia, tell us why you think the market is so confused about HIPAA.
Well, I mean, I was thinking about this today. So, right, if you think about the way the regulations are structured, basically they say there's this bolus of data that is collected in a traditional economic context by certain specified people. Those are the covered entities. And then there are basically 4 verbs that go along with it. You can have a disclosure that's required. You can have a disclosure that's permitted or use, and you can have a disclosure that's prohibited. And then it's all kind of derives from those ideas. And the basic concept is there's a bunch of uses that were anticipated to be core to the way the healthcare system functions. And stuff that's not in that core has to be authorized. But if it's permitted or required, it's kind of in this core space. And so that takes me to the fact sheets. So that's
love those fact sheets. Good pictures.
Fact sheets. Well, yeah, they were cheesy 2014 drawings, but they're also, that was all funded by the government. That was also funded by taxpayers as an educational tool. And one of the things that really struck me when I arrived at ONC was that the rules are all out there, but they're complicated. OCR has a kludgy set of FAQs. They're badly organized. If you don't know what you're doing, you can't find it. If you're an innovator, you're going to DIY it, and you're not going to hire the expensive law firm lawyer to sort it out for you, et cetera, et cetera, et cetera. And so we really wanted to create that set of fact sheets that would be something people could easily grasp the basic concepts with. That's why they have drawings, and use in their everyday business. And I will tell you, nothing makes me happier than when Omada's doing a vendor contract and somebody's like, well, so there's this fact sheet. And I just laugh. I just think it's so charming that something that I helped edit and arrange for the budget for, and, urged my staff to do and worked with OCR on. You'll note they have OCR's seal of approval. So that was the idea, was to make something that was really gave practical illustrations in the context of ONC's core mission, which was health information exchange.
Right. So why do you think, let's talk about the gray area, right? What are your thoughts on the gray area in general? Like, why do we have this gray area when we have these graphics and amazing 2014
there's a few things
diagrams
going on. I mean, there are definitely, if there's a list of permitted disclosures, let's just call it a dozen for easy. It's a little bit more than that. But if there's a list of permitted ones, but permission, the way the permission works is the disclosure gets to decide. That's the essence of a permitted use, is the disclosure gets to decide whether they're going to take advantage of that permission. You can see that you will have relationship interests, trust interests, business interests will come into the discussion about whether, when you can, you will. Right? That's a permitted disclosure. So if you think about physician disclosure for treatment from one doctor to another, that's a permitted use, which means Kat, as a specialist, can ask Lisa for some background on a patient who's going to show up for a consult. And Lisa can go, I don't like Kat. I know I'm allowed to give Kat this data, but I'm not going to, because I'm not required to give Kat this data.
Mm-hmm.
That's where the business issues
come
in, trust issues come in. That's right. Lots and lots of writing about that. I've written about that. Brendan's written lots and lots of writing about that over 2 decades, really. As opposed to the 1 or 2 situations where you're required to make a disclosure. So that's your individual right of access. And so a source of tension here is we have built our exchange model on treatment, which is a permitted disclosure, and that people on both sides of that really need to feel like they can trust each other. To be honest, nobody wants to be stuck taking out someone else's garbage if it all goes south. Just be clear about that.
Yeah.
And so trust really is key. And Doug Fritzman was not wrong when he said, healthcare runs at the speed of trust. And lots of people have said that before and after him. He's not the only one to have said that. And so you have built these trust environments. And so the health information exchange infrastructure that we have and that we've built out since roughly 2005, think about the first ARC grants. Now I'm really dating myself, but those of you who've been around as long as I have will remember those ARC grants are about a technical infrastructure in which business trust is manifested. And into that environment comes lots of new actors want to take advantage of permitted uses. We don't have good on-ramps for individual access. We can talk about that. That's a really important thing to talk about, because back to that Kat and Lisa example, if Lisa says no, and I'm the patient, I'm like, but Lisa, I want my records, give them to me, and I will take them to Kat. And by the way, I was just watching the original Roadhouse. You got to go back and watch that. First of all, Patrick Swayze, but also he carries his medical records around in a folder in his briefcase. And I'm like, wait, what? Anyway.
Oh my God.
You're all going to go watch that.
Amazing.
So
yes.
you've got to, there's these tensions between what the patient wants, what the physicians need, and the environment in which it's happening. But in the background, nobody wants to get it wrong. And so people are cautious.
Well, I mean, beyond that, like if from a realistic perspective, if you've ever tried to enforce your right to your individual right of access, anyone, somebody like me who has minor chronic conditions versus someone who has serious chronic conditions or serious acute conditions or whatever it is, it's not easy. And there are lots of decisions that were made and a lot of lobbying that was done to make it even harder than it should have been, based on all of the sort of statutory basis of some of these laws and the intentions behind them. If I were a third party, a patient in this story, and Kat was not providing those records to my physician, Lisa, if I went to Kat, I think we all know what that experience would be like. Her office manager would say, yeah, great. Here, pay this fee, and here are your physical medical records. Good luck, buddy. Like, we don't feel the need to do anything else. And you can say, here's the law, and then we never seen that before. See you later. Slam the door. Right? It's just the real. What's actually happened on the ground is not that. And then there's, of course, the fact that TEFCA, which, as we know, is still rolling out, is not going to require that individual access response in the way that it was originally intended to.
Well, and there's an important quirk in the way the individual right of access works that I think people need to be aware of, even though I personally don't like this quirk. So be clear about that. The obligation to disclose a patient's records is uniquely on the covered entity. And unless they delegate it to their HIE or whatever, the HIE isn't really allowed to take action. And what as an advocate for the patient here, I just want to know why the business associates aren't saying, look, I'm going to make your life easy. I'm going to relieve you of this burden. Here's the technology I'm going to do to accomplish that for you. Could you please just give me this delegation? Because the patient, especially in our world where people are so mobile, they're moving all over the country. I've had 4 different doctor practices in the last 10 years because of cross-country moves. I'm like, I don't want to have to go figure out how to get my data from each one.
Right. Jim notes the California Data Exchange Framework does require individual access responses, which is 1 plus mark for Data Exchange Framework out of no plus marks. Sorry, guys. I think that's interesting.
Lucia's not allowed to comment on that. That was not approved.
No, this is all me. I'm just me talking. I think it's interesting that I think the covered entity is the one who has to do it, right? Like I understand, and I just don't think the business associates have maybe if they get enough pressure, they might want to try and ask for this, but really the covered entity should just make it available. Like it is on them. They're the ones who are.
It depends on who you are, right? Like if you're think about like the self-insured employee benefit plan, what is you're going to go to your HR benefits manager and say, can I have my records? They're going to send you to your health plan or health plans. Like, I think there's, for the individual right of access, there's a lot of use cases where having the custodian of the data, not the covered entity, have the responsibility.
Yeah, definitely.
Yeah, I agree. Well, let me stick to the questions that I would like your PR team to let you back. So tell us. Okay, no, that's fine. That's fine. This is like the first time we've actually like done this, so I'm like actually reading the questions. Okay, so on the national exchanges, everybody's like, wow, like. But HIPAA covers TPO purposes of use. Like, why do the national exchanges only do treatment? Like, why are they only doing treatment right now? And why is TEFCA only starting with treatment?
So I don't have an opinion about TEFCA. I'm not a giant fan of TEFCA. I don't really think that I see TEFCA as kind of like a uniform contract, and I've been in business too long to feel like boilerplate contracts are going to work. Like even BAAs, which are the most downloaded sample contract in the federal government, don't really show up in a cookie cutter way. I think it's because that's the use case that the people who have the most informative data are the most comfortable with, right? And exchange has happened for decades. Before we put in care quality, before we put in the QHINs, people were exchanging by fax. And before it was fax, they would call each other on the phone. The specialists, medical assistant would call the primary care's medical assistant, and they would compare notes about a patient. And so people are used to having these trusted relationships within their own referral patterns, et cetera. Now, obviously, there's lots of upheaval in healthcare generally, but that's why I think it started there. So that's the use case that the people with the most informative, the most sensitive, the most private data were the most comfortable with.
All right.
But
Do
I
you
also go
feel
back
like
to, let me just add one other thing, going back to the origins of HIPAA. It started with claims data. So one also has to remember that all the data that you give to your doctor when you go see them turns into parts of claims data, which then are automatically sent to health insurance companies. That's not even considered health information exchange. It's just a core part of that original thing we looked at 20 whatever years ago.
Got it. And do I see here in comments, is this your husband, Mark S., who wrote the high freaking five? So y'all, credit.
I wouldn't say he wrote it, but he's a big mover and shaker on that California Digital Health Framework and the individual access.
There we go.
So you can have him on to ask him about that.
Well, there you go.
You can't hear me say that.
Oh my gosh. Well, all of y'all who live in California, all 39 million of you, 10% of the United States of America, you can thank Lucia's husband, Mark Savage,
biggest economy in the world. They just updated the numbers. Come at us.
Well, God bless California. God bless the great nation of California. You, as a citizen of that state now, can access soon can access your own record. Which
don't ask about the details, Kat. Come on, you know better than that,
Lisa. You know I only read the headlines. Anyway, okay. So one more question for you, Lucia, because it was approved. Your hopes and dreams for TEFCA.
What I would really like, what's reflected in many things that I've published, so I'll start with a fact sheet. I'm like, we have these ways in which we're allowed to disclose when the right amount of trust or the right amount of commitment to stand by your own mistakes exists. And that's what I really hope, is that people, as we build out exchange to benefit the patients, to create the paths to address inequity. Like, we need this so desperately on an analytic level, that people recognize that they should deal with their own garbage. And I'll give you an example, actually, from early HIE days. Back in the day when I worked at United, we were looking at joining the Arizona HIE. This is before high tech, like in that moment, just before high tech was enacted. And we did an agreement. It was based on derivatives from the DIRSA, again, a standard template that was never widely adopted. It was perfectly acceptable, but we modified it. And one of the things we modified is that everyone who participated agreed to basically clean up their own messes, right? So if you are exchanging and you disclose wrongly, you have to go clean it up. And it's not right. And you have to know that you've cleaned up. If you put bad garbage in the data system, you've got to take the garbage out. It's hard. nobody really wants to do that. There is liability that attaches here.
It's really hard.
But if you do it carefully and responsibly, it should work.
Yeah, this is the classic problem that we've been, we've talked about multiple times, right? All of the out of date or incorrect or incorrectly entered data that's made its way into all of our records, things that are not relevant or things that were incorrect. Here we are, and you can make a mistake. I think there potentially were some, as far as we can tell, data disclosed through these latest potential breaches. I don't know if they really are breaches. That's up to the hospitals and the health systems who have to deal with that. But okay, what are we going to do now? What's next steps here?
Yeah.
Was something
What do we do
incorrectly
now?
shared, or were there mistakes entered? What does that look like? I don't know.
Right.
Yeah.
Right.
Yeah.
It's it's very tricky space, and I also think that I'm not full-time lawyers forever, but I do think that having counsel who really understands not only what is the law trying to do, but how does it accomplish what it's trying to do is going to be really key. Even if we have APRA pass, you're going to have somebody who really understands the environment in which all this activity is happening. I love Brendan, but this is not a DIY situation. If you're advising one of these businesses or you're a patient trying to execute your rights, you need to be very precise about what you're trying to do.
He is this is not legal advice. His
he
first
does have a disclaimer.
Not an attorney, not legal advice. Do not build your business on my blog post. He's very clear about that. And I just think understanding the issues is more important.
I will say you can quote those fact sheets though, because they've gone through the government clearance process. They have OCR's seal of approval on them for a reason.
Nice, that's awesome.
Nice.
Oh my gosh. Well, there we go. Yeah. Well, fantastic. And we do have our favorite lawyers. We've had them on the show. I don't think Lucia's for hire, but we have some great lawyer friends for hire, like Alia from McDermott. Yes, she's great. Who else do we like, Lisa? Do we like anyone? I don't know.
Referral.
We like her.
A lot of them have actual jobs. They're not ready to sort of provide
we have lots of lawyer
person.
friends. With real jobs like Lucia. So, so anyway, okay, Lucia, any parting words? We're going to go talk about pharmacy interoperability. I feel like we totally didn't get in trouble. We read our questions.
Yeah, we're good.
We're
good.
Yeah, we're fine.
My parting words are, I think there are so many more important things to focus on than particle versus epic.
Nice.
That there's so many things we need to fix in the healthcare system. It's great that people are thinking about this, but I think it's less about these particular companies and more about, are we finding the pockets of inequity? Are we finding the places where people aren't getting the care they need and fixing those things? Are we developing policy for new modalities of care, to Lisa's point earlier, where, huge swaths of the American population can be served by care delivered via smartphone technology? How do we make sure that the professionals doing that care get paid fairly for it? That's a much bigger problem.
Yeah. Workforce shortage, all the things. Absolutely.
Yep.
All right. That was
thank you for having me.
Awesome
It was really fun.
Yep.
Enjoy your vacation.
Lucia,
I will.
Also join us on vacation. So enjoy. Okay, next, you guys, we are moving on to
oh my gosh,
Pooja Babra from Point of Care Partners. So I don't even know if you guys know this.
Also,
but,
I don't know if it's real background, but she also has a similar background to yours. Looks pretty fancy.
I do.
Hers looks like it might be a little bit better. But that's all right. That's all right.
If you watch any of our early episodes of our podcast, I literally sat on a couch for 3 years. So it's nice to finally have our office built out.
Upgrade. That's awesome. Okay, so we know we're going to talk about pharmacy stuff, I think. But Pooja, please tell our loyal fans, of which we actually have about 45 actually watching right now. So that's I don't know. You never know what's going to happen. Tell them who you are and why you're awesome.
Of course. Yeah. So Pooja Babra, I am the pharmacy and PBM practice lead for Point of Care Partners. So I'm sure a lot of your loyal fans know my colleague Jocelyn Keegan, who is program manager of DaVinci. So Point of Care Partners, health IT consulting company. We do run a lot of accelerators. Vanessa Candelora, who runs Gravity, and then we're involved with a bunch of stuff. But yeah, my background's strategy, product management. Have been doing product management in the pharmacy space for, gosh, I realized almost 30 years now. So kind of scary. But yeah, it was around early days of e-prescribing, even before SureScript started, when it was just in its infancy. So have been around for pharmacy space for a long time. Not a pharmacist, but know a lot about kind of the workflow and the standards and all of that. So yeah, that's
Awesome.
my background. Yes.
Very cool.
Nice.
All right. So, like, from what we understand, you're doing like all this work getting pharmacies like connected and like exchanging information, and like it sounds like also like enabling them to like operate more effectively and like the full license, like that whole discussion. So, like, just tell us, like, why are you working on this? Like, why do you care, and like what's happening?
Yeah, definitely. So, so pharmacy interoperability. So I also sit on the board of NCPDP, and so people kind of forget about pharmacy when we talk about interoperability, right? It's always between payers, providers, and patients. And I think it was during the pandemic that we really saw what pharmacists could actually do. I always ask this when I'm doing panels, and it's like, how many of us went to a pharmacy, right, to get our vaccinations? So many hands go up. And so it was this recognition that pharmacists can actually do more than put pills in a bottle, and they should be, right, because they go to school. They are doing a lot of the same training, to do a lot of the clinical services as well. So part of what we want to start talking about is how do we get pharmacists wrapped into that same, as part of the care team, doing things for patients, and that includes getting the patient record right to the pharmacist. So this is an example I use all the time, right? During the pandemic, we were so excited when our pharmacists could actually prescribe Paxlovid, right? So they could test for COVID and then they could prescribe. And what people
Test
didn't
to
realize,
treat. Test to
yes,
treat.
test to treat, exactly. But if you read the small print, it was like, yes, you can test and you can prescribe, but you also have to have the lab results, right, of the patient to make sure their kidney is okay. And we all know, unless you're part of a health system and you can access, right, the Epic EHR,
Health
you're not going to have
records.
that information,
What?
right? So
Crazy.
it was
That's
kind of like,
insane.
okay, right? So that's what we are now saying, hey, if you want to improve patient outcomes, include the pharmacist as part of the care team. They're seeing the patient a lot of times more than the provider does. You guys talk about rural areas on this show. I mean, there are rural areas where the only person around, right, to technically take care of a patient is a pharmacist. So if you're not giving them data, and we don't need the whole patient record, right, just the pieces they need. But if you're not exchanging that data with a pharmacist, it makes it very difficult. So, that's what I've been kind of working on, both from, in the point of care partner side, but also with NCPDP. And then ONC actually had a high-tech task force that was focused on pharmacy interoperability. Yay, big shout out to Trisha Lee Roll, who is the pharmacist, that kind of led that effort. And we ended up with, I think, 32 recommendations to ONC of like, hey guys, we need to start thinking about certification. Now that TEFCA is rolling out, how do we make sure pharmacists are included? So yeah, all of that, which is just so important, I think, for patient care.
Just major for workforce shortages, like you said, right? I just think first and foremost, workforce shortages, there's a lot of things that a pharmacist can do if they're allowed to practice at the top of their license. And so much that like comprehensive health data and being part of the care team from a data perspective can do to make that possible. I mean, I just there are people who see their pharmacist who go into the pharmacy like every week, certainly multiple times a month in some cases, right? It's just, it's such a huge missed opportunity. From the HIE side, as you know, there are only a couple of HIEs who are sort of getting the full scope of pharmacy data, and others who are getting bits and pieces. And that really tends to be just a state sort of organization and perspective. Like, we should be including all of this. We should be bringing the pharmacy data through here. And there's also some big issues with PDMPs, as Kat well knows.
I'm trying not to lose my shit about PDMPs.
Look at her face. Look at her face. She's like,
I was Anyway, the point is, I think that PDMP or pharmacies should totally be connected to their HIEs, not because it's a workaround, Lisa, because it is the right thing to do.
Yeah,
That's
well,
right.
shout out to MyHin. So I literally got back last night from a meeting with MyHin. So they had a third workshop yesterday, right, of bringing pharmacists together and providers
Nice.
and to say, hey, how do we start working
How do
on
we
pharmacy
make this
use
happen?
cases?
Right.
Oh my
Yeah.
gosh, I was just like, I literally like came back with like 10 pages of notes. I'm just like, big shout out, right, to MyHin for doing that. And the use cases were, how do we make sure that we get pharmacist to patient record? How do we get a comprehensive medication record for the patient for, the population in Michigan? So there's pockets of people doing this. And I think it's so like, again, big shout out to MyHin and others. I think North Carolina, I think in Maryland, they're doing some, Nebraska is another one. But to me, also with TEFCA, let's start talking about how to bring pharmacists in. So the other thing that Sequoia Project at the annual conference last year, I think it was October, November, I can't even remember, we did get on stage and we said, hey, how do we get a pharmacy work group under Sequoia Project so we can start talking about this? So hopefully, fingers crossed, we'll start to be able to at least think about that to bring folks together. And I think it's just partly because, for the high tech task force that we did, I feel like we spent maybe the first month just educating people. And, part of it
Right.
was like, why are we even talking about pharmacists, right? Like they just put pills in the bottle, but it was kind of like, no, like let's think about everything we're
No.
doing. And we had amazing patient advocates on there that are like, I work with my pharmacist, I do this. So, yeah, it's just such an important topic. And I have to tell you, after years and years of kind of doing this stuff, it's nice. I mean, everywhere now people are talking about pharmacy interoperability, which is very important in my mind.
That's
So, yeah,
awesome.
huge kind of passion of mine. I know you guys talk about passion projects, and this is
We
one
sure
of mine
do.
for sure. Yeah,
That's
yeah.
like
So
that's your day-to-day work though, Pooja, and
it
you've been doing
is.
it for a
It
while.
is.
I think
And
Uh-huh.
I
you're an
also
expert,
I just
and
I just get really concerned about I mean, okay, so going to another tack, right? Thinking about
Yep.
telehealth and by the way, we didn't talk about it, but I think that Optum's like virtual like telehealth arm just like laid off their entire staff, which is interesting.
Oh wow.
That like just
Yeah.
happened.
really,
So TBD on that one. But for telehealth, like there is a massive risk of, a totally disconnected, not part of a longer term care team
Yeah.
provider, you know, doing like prescribing something with like no med rec and
Yep.
no other sort. So it's just like there's different. You can look at it from different directions, right? Like
Yeah.
there's the pharmacist who works in a retail pharmacy or even in a hospital pharmacy in some cases who are not getting the full picture of records, and there's also just like providers who are disconnected, not getting pharmacy records, right? It goes in
Yeah.
all directions. It's
Yeah.
really concerning.
It is.
hmm.
Yeah, and that was one, so ONC wanted us to focus on kind of the new pharmacies, right? The hims and hers that are writing these prescriptions without having any of that. So I think that's part of the discussion too. And it was one, we just didn't get to it. We had so many topics that we were trying to tackle in that task force, but it was kind of like, okay, how are you going to manage now with all these new types of pharmacies kind of coming in the mix, which is something we're going to have to deal with. But we can't even, we can't even get a comprehensive record from the information we have currently.
Yeah,
So that's kind of all
yeah,
right. How do we tackle that first? So yeah,
And didn't the
yeah. Well, that,
DEA just punt on controlled substances? Didn't they just say like we're not going to decide or they're if they're going to extend it or not? The pandemic sort of loosening
yeah,
of controlled substances prescriptions,
I
telehealth
think
via
so.
telehealth.
And yeah, and it's so funny. So I,
Oh,
before
great!
consulting, I actually used to work for Doctor First. So I did launch the first controlled substance like product to the market, which was
Wow.
right
fascinating.
on.
It was, yeah, I actually went through the DEA audit, which was very interesting, whole nother discussion, but it was kind of like, yeah, I think we can do this. Yeah, that makes sense. You're kind of the first one going through. So it was like, how do you interpret this? But the one thing about controlled substances is, the telehealth and those, and how do you make sure that people are actually, so there's a whole thing you have to sign, right? You can't just send it as a regular prescription. You have to have this
Hmm.
two-factor authentication. It has to be direct to the pharmacy, so you can't tamper. And the one thing that was really interesting, attended a session on pharmacy and AI, and they said, how are you going to know maybe if someone can hack into that now, right? And that's another big thing as well. But yeah, I didn't see anything. I didn't see about the telehealth and EPCS on what's
We'll
happening
put that
there.
in our next show. We'll put it in our
Yeah,
next show.
yeah,
But hey,
definitely.
I actually don't know a ton about pharmacy interoperability other than I really love laws that somehow are launched in states that require pharmacies to be connected to their HIEs. Like weird. I love those. Maybe I don't
It's
know.
great.
But question for you about you. You mentioned that what ONC asked you to focus on was the newer pharmacies. But like I we do love rural health here. I love rural health. I spend a lot of time hanging out in West Virginia. And one of the reasons their early vaccination response was so good during COVID was because the independent pharmacists who, really were ingrained in their communities and were driving around to houses and everything. Like,
Yeah.
does that mean that's kind of like we're not worried about them right now? Like, we're worried about help me understand the prioritization
Well, no,
with
I
getting them
mean,
connected.
absolutely. So most of the recommendations and the topics we were talking about is how to continue to make sure that pharmacies, right, community pharmacies and others are connected, they're getting information. Because if you think about it, there's so many different types of pharmacies, like you said, right? Community pharmacies, retail pharmacies, online
Yeah.
pharmacies. And to me, the community pharmacies are the ones that are really stepping up to do some of the patient care.
Hmm.
Um, one of the problems is reimbursement, which is a whole nother topic that we
Yeah.
can need to tackle. But you should also make sure, they can do MTM, the medication reviews, things like that, and get paid for it, but they also need the data. So, we are a lot of focus on kind of that community pharmacy because they really are the ones that are stepping up. Another thing, friends of your shows, right? The Direct Trust folks, Catherine and Scott, we are talking about how do we get ADT notifications to
Mm,
pharmacists. And I think that is a huge use case for community pharmacies and the rural pharmacies. So if you have a patient that's gone into the hospital or getting discharged, wouldn't it be great if the pharmacist knew, right? So you're in the hospital, you're going to long-term care, they don't need to fill your maintenance meds. Or another case, you're getting discharged and they need to have the meds, ordered for you, right, as you're getting discharged from the hospital. And there was someone, we brought this up at NCPDP, and someone that I know said, hey, I was in the hospital, got discharged. I live in a rural area, and my pharmacist didn't have the drug I needed, and I ended up back in the
yeah.
hospital because they couldn't get it for a week. So it was kind of like this realization of, okay, why are we not sending ADT notifications? And to me, that's a huge opportunity for community pharmacists to be, because they're the ones that have such great relation. I mean, everyone does, but
Yeah.
they do
Yeah.
have that relationship with the patient, so they can do that. So lots of different areas, lots of topics to kind of to focus on. But that's another one I think that is really important around all this. So,
Yeah.
Nice.
but,
So,
yeah,
we got a lot of loyal fans here, and many of whom came to watch you, Pooja. So, and again, like this is like, despite the fact that like we should have cared about pharmacies a long time ago, it is like relatively, like kind of like new-ish on the scene.
it is.
So, what
Yeah.
would you leave all of our loyal fans with? Like, what should they be doing, assuming they all believe that we should be getting pharmacies connected more
Yeah.
broadly?
Yeah, I think the biggest thing, and everyone, right, the data connection. So, when we're sort of talking about TEFCA, HIEs that are out there, the funny thing is I hear when I start talking to some HIEs or some of the QHINs, it was like, yeah, we didn't really think about pharmacists. So let's
Mm,
start thinking about pharmacists. Let's think about, how do we get the data? And they should also be sharing data back. So, pharmacist does an
yeah.
intervention, how do we now have that two-way communication, which is super important. So I would just say when you're thinking about care teams, data sharing, patient information, make sure you're thinking about the pharmacist as part of the care team too. So that
Got
Nice.
it.
is,
All right,
yeah,
loyal fans, you heard it direct from the source. Okay,
yeah,
Pooja, thank you so much. We are going to
Thanks,
close out here with
Pooja.
some
absolutely. Yeah, thanks for having me.
comments that we got. You're the best. Thank you so
Great
much.
comment.
And Lisa, we got some. Hold on, this is like, I mean, without Melissa, we're basically lost.
I
Tom
know.
Novak is taking some credit for the fact sheets. He said, I think the fact sheets were from 2016 because I linked to them in a 2016 Medicaid, state Medicaid director's letter. So apparently Tom was also involved, just in case anyone was curious. What other comments do we have? Nadine says she really appreciates this garbage in, garbage out comment from Lucia. Brendan's going to be president. I think that's mostly it. We had like a very lively discussion with our.
Yeah, Deanne shouted out that there should be a rule at the end of the year from the DEA on prescribing of controlled
right on.
substances. So something is going to come out. The problem, as we all know, about regulations that come out at the end of a presidential term is that they don't tend to last if somebody doesn't want them to last. So I'm a little concerned about that. TBD. Hopefully it works out.
Yeah, I will say our super fans were all on Vimeo Live today. The real policy nerds were there. Yeah, so okay, last announcement. So Lisa and we are traveling. Here we are. Lisa is going to be. She's going to have her own slides soon, but. Right now, we're just also, if you guys send us tips and specifically earmark them to get Stefan a new headshot so that he can afford that.
Get Stefan
we will get that done. He tells me this is from 2010 or something like that. But anyway, so both Lisa and I are speaking at the Young Health Leaders Summit from the Advancement League. It is in Miami, May 16th and 17th. It's going to be awesome. And we're doing a live health tech talk show there. So email Melissa at Health Tech Talk Show. She will also be there. She is the real draw, as everybody knows. So email her if you'd like to be a guest in the show and you're attending. It will be live. We're not taking anyone remotely for that. So also tip us, no big deal. And then we are probably most likely still, going to cover Health Europe in Amsterdam, assuming we get enough funds to cover Lisa's travel.
Looking for some sponsors. So if you know anybody, feel free to sponsor us to attend Health in Amsterdam. It's going to be great.
It's basically going to be amazing. So I think that's pretty much it, Lisa. I think it's all we got going on. And then tomorrow, next, I will tell y'all, this is what's happening next Friday. We were going to have a show.
No.
We are canceling it. It is a national health tech market holiday. Leslie Kirk is getting married next weekend. Lisa will be flying in. I'm apparently giving a speech on Friday night and Saturday night, as far as I know. So I'll need to write that speech and also pick up Lisa from the airport. And we're not going to be able to have a talk show. But we are going to make a special announcement with a substitute podcast, even though this is not a podcast. It's not a one-to-one. A special friends podcast we will be announcing, and you can listen to that insteut of us.
More to come soon.
It might. We don't know. We're not sure. It might also not be ready. We don't know. We'll let you guys know. It's going to be great. So anyway, thank you, loyal fans. Thank you, Lucia.
Thanks,
thank you,
everybody,
for coming on and telling us all the things. All right, we're done.
You're the best. Have a great weekend. See y'all later.